A lot of this particular section, I think, is information that I would suggest that you know in order to help you answer questions. And I'll help you to hopefully understand what I mean by that as we go through this. So the next sections to make up about 8% of the content domain and is the highest percentage of any content domain on the certifying exam. And again, that includes not only growth and development, but vaccines and some aspects of well child care as well. What I meant earlier was, again, they're not going to ask you what growth chart do you use, but it is important to know the differences between the WHO growth charts and the CDC growth references, because a relatively new recommendation has been to use the WHO charts for all children under 2 because they have included in those growth charts measurements in a breastfed population. And some of the standard CDC charts, especially for those under 2 years of age, oftentimes miscategorize breastfed children as being either underweight or also overweight. So that's why the WHO growth charts are preferred in the younger population. Now, I think the key point to this slide is, again, they're going to give you, for example, a birth weight. And then the scenario will involve, for example, a 5-month-old. And so they'll say the birth weight is such and such, his current weight is such and such, and then you're going to have to make a decision as to whether weight gain has been appropriate or not. So the parameters I would know for the boards for this would be when children should be expected to regain birth weight. So you know if you have a 3-week-old, whether that 3-week-old is gaining appropriately or not, and when weight should double, triple, and quadruple. And that way, using the birth weight information in a 6-month-old or in an 8-month-old, you can tell how well or how poorly that individual child is gaining weight. The other key thing to keep in mind is that after 24 months of age, children in general should gain about 1 kilogram per year. And so knowing birth weight, when weight doubles, triples, and quadruples, and expected weight in older children will help you to evaluate, even though you're not told that that child is failing to thrive, will help you to make that decision. Same thing goes with length. Length should should increase by 50% in the first year, double by 4 years, and triple by 13 years of age. And that bit of information will help you to assess whether the child is growing appropriately, as will the fact that you should in later life expect, and this is prepubertal, children to grow at least 5 centimeters per year. So I would commit those particular parts of the slides to memory to help you sort through questions. Know this, know what the average head circumference is at birth, because when you're provided a head circumference in a newborn, well, that will help you to assess without them telling you, because again, they're not going to tell you whether the child is microcephalic or macrocephalic. And in addition, know that the majority of head growth occurs during the first several months of life, as is outlined here. And then really the vast majority of head growth is completed by 4 years of age. And keep in mind that transition to BMI assessment should occur around 2 years of age, and also that these definitions that we went through earlier in the adolescent section also pertain to younger children. Another thing in this afternoon's talk is there's going to be some slides that are repeated from a couple of my previous talks, and that is not that we're going to go through those slides a second time, but hopefully so you won't have to go back and forth between topics when relevant slides are occurring in more than one talk. So that's the reason for the repeat. Okay, so let's look at some specific growth disorders and start with an audience response question about this 6-month-old here for a well child check, new to your practice, height and weight plot at the 5th percentile for age, history and physical are unremarkable. What's the next best step in the evaluation of this particular patient? Growth charts or basically specific workup from a metabolic standpoint. Okay, great. So take-home message, don't do anything until you get more information. You're not going to want to make the diagnosis of failure to thrive based on a single measurement, if at all possible. So always try to get old measurements, and then once you get those old measurements, look for the direction of growth, look how or if it has changed over time, and especially important if you see a growth chart that shows crossing into other percentiles, especially crossing more than 2 percentiles, that should raise a red flag, because so much of growth disorders, your answer is going to be reassurance, reassurance, reassurance. And a lot of what we're going to be talking about, therefore, is red flags that would make reassurance the incorrect answer. And certainly crossing percentiles is one of those that should prompt additional workup. So what about preterm infants? If you're given a weight or a height on a preterm infant, and now that infant is, say, 12 months old or 18 months old, how do you know whether that particular infant is now failing to thrive or whether his particular weight, although low, is still okay because of his prematurity? So be sure to always correct for gestational age. You can see the correction there. And then correct for 24 months for weight, 40 months for stature, and 18 months for head circumference. So again, before you identify a premature infant as failing to thrive, be sure that you look at that infant's chronologic age and see if he or she is still within this age range to make an adjustment and therefore not initiate additional workup. Know also that there are special growth charts available for a variety of disorders, but in general, as I said here, for the majority of preterm infants, except for those who are very low birth weight, it's appropriate to use the standard growth curves. So let's look at some specific growth problems that you might see on the exam. A prenatal event will be defined as birth weight, height, and head circumference that are all low and that continue to fall in a downward direction after birth on each of these 3 parameters. So if you see this type of growth pattern and are asked, for example, what might be causing this, look in your answer options for a prenatal event. That again includes all of these particular categories here, related basically to complications of pregnancy, a genetic abnormality, or maternal substance abuse. So, prenatal event. What about a postnatal event? Early growth parameters tend to be normal. That event then occurs, and then the parameters begin to fall down from previous growth. And this too affects head circumference, weight, and height in an equal way. So starting off the growth parameters as normal and then changing is equivalent to a postnatal event, again affecting all 3 growth parameters. So both prenatal and postnatal affect all 3 growth parameters, but the difference is when the percentile crossing begins. And then finally, if the growth pattern is a caloric insufficiency, you can be pretty confident that for the most part, it's going to be the weight that's affected rather than all three like they were in prenatal and postnatal. And once the weight loss becomes severe, then maybe the other parameters will become affected. But in general, it's either significant weight loss or failure to gain weight with caloric insufficiency. So just by looking at when the particular weight loss occurs can help you sort through a prenatal, postnatal, or caloric insufficiency cause of the weight concerns that are talked about and illustrated in your vignettes. Okay, remember also that most children who are SGA, or small for gestational age, will catch up, but about 10% of them, for a variety of reasons, may not catch up. And if you're asked to provide anticipatory guidance, for example, to parents who are asking, is my child going to grow like other children, even though he was born small or she was born small, you really can't answer that question until at least 2 years of age, because again, the majority will catch up, but some unfortunately do not. And those that do not tend to have a maternal history of significant complications either during pregnancy or at birth. All right, so second question. This is a small 8-year-old, firstborn, no problems during pregnancy, healthy with a negative history. Growth parameters at birth and for the first several months were around the 25th to 50th percentiles. Then they crossed percentiles. All growth parameters gradually fell to around the 3rd percentile, and they have stayed that way at least over the last several years. Mom and dad are in the 25th to 50th percentiles. So started off, then dropped, then sort of found his own curve, so to speak, and now is here, and mom and dad are concerned. So what's the most likely diagnosis accounting for this patient's pattern of growth? Celiac disease, hypothyroidism, growth hormone deficiency, constitutional growth delay, or genetic short stature. Good. So constitutional growth delay is the correct answer. This is much more common among boys than girls, and let's look a little bit more at the specifics of that. The reason that a constitutional growth delay is often on your boards is, you notice I said this is associated with crossing of percentiles, and almost always that's a red flag for an underlying disorder or for the need for workup. This is an exception to that. So constitutional growth delay is usually familial, characterized by normal birth, weight, and length, and then a downward shift that begins somewhere around 4, 6, even 9 months of age, and then continues. Then typically parallels a lower percentile. So they start in the 25th and they drop over a period of months, hit the 5th percentile, and then they stay on that 5th percentile for several years. Puberty is delayed, but once puberty does begin, rapid growth occurs. The percentiles are crossed in the opposite direction, and typically these children, although late, will achieve adult height in normal range. So ask Dad, was he a late bloomer? And he might say, yeah, I was the shortest kid in the class until I hit junior year in high school, and then I shot right up. So this is a benign, no need to investigate, with one exception. And how might you investigate this to confirm it? And you do that with a bone age. So here's the question. What bone age would you expect in this 8-year-old child now that we believe he has constitutional growth delay? Will bone age be delayed, advanced, normal? Is there no relationship? Or is bone age not even indicated? I guess I gave that one away. Don't answer E. Okay. Good. So it's delayed. So what is bone age? How can it help you? And how can it help you sort out between genetic short stature, idiopathic short stature, and constitutional growth delay? For one thing, bone age is a really nice test because it doesn't hurt, it's quick, and you can get lots of information from it. So here is what might occur. You get a bone age equal to the chronological age, a bone age that's older, and a bone age that's younger. So let's figure out what might cause that. Constitutional short stature, the bone age is delayed, and it equals the height age. The height age is the age at which the current height is equal to 50th percentile. So for example, if we go to a growth chart, and on that growth chart, an individual who is 10 years old has a bone age, for example, of 8, that bone age is likely going to equal that child's height age, which again is the age at which the current height is the 50th percentile. So if my current height is in the 10th percentile on the growth chart, I move back until I hit that age on the growth chart where now my current height is at the 50th percentile. Does that make sense? Yes, no, maybe? Okay? Because the height age is really an important concept. And height age equals bone age equals constitutional short stature. If chronological age and bone age approximate one another, that means you're short because you either are genetically programmed to be short or because you have idiopathic short stature. Now, how do you tell the difference between idiopathic short stature and genetic short stature? The key lies right here. Are you going to be predicted to meet your mid-parental height, or are you going to be below your mid-parental height? So how do you figure out mid-parental height? This is the formula in order to do that. So you have mom's height and dad's height, and mom and dad come in and say, how big is Johnny going to be when he is 16 years of age? You can use this formula to give them an answer. And over time, if that formula predicts the final height, then that individual has genetic short stature. If, however, over time, that child, based on his mid-parental height, his mom and dad's height, is expected to be 5'10", and he turns out to be 5'5", then he has idiopathic short stature. So I would suggest that the very first thing you do, if you're given the option in a vignette, to evaluate a child with short stature, get a bone age. And know this particular slide, know your definition of height age and bone age and chronologic age, and know this particular formula, and then you have a pretty good idea as to whether or not you need to advance and do some additional workup or just sit tight. Okay? All right, so here's the growth charts, and let me just to illustrate this. So let's say that, let's make believe this said constitutional short stature. So here is a 10-year-old who has this height. So if you want to figure out his height age, move back until you get to about here, which is 8 years old. That means his current height at 10 is equal to the 50th percentile for an 8-year-old. If his bone age is 8, then his bone age equals his height age, and therefore he has constitutional growth delay. If his bone age is 10 and his chronological age is 10, then he has familial short stature or he has idiopathic short stature. That's where your calculation for mid-parental height will come in, and you can figure out those two. Hypothyroidism, a very classic growth chart where suddenly stature stops and weight increases. I can't imagine the number of times I've checked a thyroid. Only one time have I identified a hypothyroid child. And quite literally, Mom's chief complaint was, he keeps getting fatter, but I haven't bought pants for him in regards to being any longer for the last 5 years. That was her chief complaint. And you almost kind of knew what the problem was just based on her chief complaint. And then any chronic disease over time will certainly affect first weight and then length. So lots of information that you can gather from a bone age and from looking at a growth chart that will likely appear on some vignettes on your boards. So we've talked about failure to thrive. This is not failure to thrive. That's not failure to thrive. Let's look a little bit more carefully at what failure to thrive is indeed. So definitions vary. Usually it's poor weight gain, not so much actual weight loss, except in severe cases. And weight is affected first, then height, and lastly, head circumference. So this would be considered a caloric issue, and therefore weight first, then height, and finally head circumference. Now, although we don't like to use growth charts when we just have a single point, if that's all that they give you, then here are the definitions from a single point. Here are the definitions from a series of points. And again, always beware when 2 percentile divisions are crossed. Now, infants by definition with familial short stature or with constitutional delay should not be identified as having failure to thrive. So, which one of the following is the most common cause of failure to thrive that we see today? Inadequate dietary intake, disorders of malabsorption, or of congenital heart disease, recurrent urinary tract infections, or metabolic disorders. Okay, absolutely. So let's look at that a little bit more carefully. Failure to thrive, let's look at the overview of causes. Insufficient, usable nutrition secondary to inadequate intake or to inadequate nutrient absorption. How about if the patient has an increased wasting of calories, such as through urinary or intestinal losses, or perhaps has increased nutrient requirements due to, for example, severe congenital heart disease? Or is there ineffective use of the nutrients, i.e., from an underlying metabolic problem? So are you getting enough? You're getting enough, but you can't absorb it. You're getting enough, but you're losing too much. You're getting enough because you need more, or you're getting enough, but you're not utilizing it appropriately. And we'll look at all those categories in a little bit more detail. The majority of cases are indeed due to inadequate dietary nutrient intake, most all the time due to psychosocial factors in regards to family unit and or a disturbance in feeding behavior. And oftentimes the disturbance in feeding behavior is again due to, for example, problems with maternal bonding and the like. Occasionally, a disturbance in feeding behavior will be due to oral aversion. If a child's been in the NICU for a long time, been intubated on multiple occasions, that child may have oral aversion. Usually, you will not be able to identify an organic etiology. They rarely present as failure to thrive alone. And in your vignette, if a child is described as failing to thrive, I would really can't think of a scenario that I would work that child up unless you have some other evidence of developmental delay, chronic illness, or abnormality on the exam. The answer almost always is going to be feed and observe before you work that child up, unless the vignette gives you some information to suggest that that child is chronically or acutely ill. So inadequate dietary intake. Maybe the calories just aren't offered and or the calories are not ingested. Again, oral aversion. And severe psychosocial failure to thrive. Unfortunately, I would guess that all of us have seen it. These children have what is oftentimes described as an apathetic withdrawal, poor eye contact, or eye contact that almost looks as if they're watching every move you make out of fear. They resist being held, prefer interactions with inanimate objects, and have significant developmental delays. And again, unfortunately, this is the most common presentation. So failure to thrive due to psychosocial situations or inadequate intake used to be a rule-out diagnosis. Used to be that we get the full metabolic workup, some neuroimaging, and if everything was okay, then we call it psychosocial. Now it is flipped 180 degrees, and you should consider this in any vignette as the initial diagnosis unless you have clues to suggest otherwise. Now, what is the differential diagnosis of medical causes? Again, about 5%, 8% of failure to thrive is due to a medical cause. But if you have information in your vignette that suggests a medical cause, you're still going to want to work through how best to work that up. So there are two classes. The first is caloric wasting, and causes of caloric wasting are generally gastrointestinal or anatomic. The need for increased and renal. So gastrointestinal, anatomic, or renal. Those are your causes generally of caloric wasting. Your causes of increased caloric requirements are more cardiovascular, endocrine, or malignancy or infection oriented or caused. So caloric wasting and increased caloric requirements really have a different group of organ systems, so to speak, that most likely cause those particular issues. So as you begin to evaluate for a medical possibility of failure to thrive, obviously history is going to be important. And again, you may, even if you are suspecting a medical cause, you may quickly rule that out by getting a disturbing dietary history or observing the child as apathetic and disinterested. But certainly you'd want to ask about excessive loss, either through vomiting or diarrhea. Be sure, if they're formula fed, to be sure that that formula is being mixed appropriately. And if it is not, then the next best step is going to be get a metabolic panel to look for hypo or hypernatremia, depending upon the mistake that is being made during mixing. And if mom is breastfeeding, be sure that her milk is in, that she is aware that her infant is swallowing, and that her breast is empty at the end of feeding. Perhaps you learn that mom had a CMV infection. Here's a CMV infected cell from the placenta, which would account for failure to thrive. So medical evaluation begins with a careful history. History in the older child should also include questions about juice intake. These are the most recent recommendations from the AAP. If you were to be asked about the appropriate amount of intake of juice on an exam, there are your answers. But I think we've probably all seen children who drink excessive amounts of juice during the day, don't thrive well, oftentimes have some chronic diarrhea, and it can save a large workup if this information is obtained by history. Now, again, what other clues might you get on history? In other words, might you read in your vignette? So here's a buzzword: a child who is tiring and crying and diaphoretic with feedings oftentimes will have an anomalous origin of the coronary artery. Basically, that describes baby angina, because the most work that babies do is to feed, and during feeding, because the coronary artery is compressed, it can be a left coronary or a right coronary artery, is compressed during each ventricular contraction, the child becomes hypoxic, sweats, tires, and cries. And so that is a buzzword that you have to get a cardiac workup. Other things to keep in mind: endocrine, history of constipation, decreased activity. Two more: prolonged jaundice in the NICU or the presence of an umbilical hernia. All of those associated with hypothyroidism. Endocrine, obviously also polydipsia and polyuria. Foul smelling or fatty or mucousy stools, certainly suggestive of a malabsorption. And the term voracious feeder or active feeder or anxious to feed even after vomiting, all are consistent with pyloric stenosis. And so those particular buzzwords in your vignette can help you more readily choose the best next step in the treatment, because all the steps are going to make sense. And so you've got to figure out which one is the best based upon the information that they're giving you. Now you're on to the physical exam. Now, obviously, if there are dysmorphic features, there's a significant murmur, if there's an abdominal mass to suggest a Wilms or a neuroblastoma, or signs of respiratory distress, then obviously this will merit more of a workup than one would normally perform when considering psychosocial factors of failure to thrive. And signs of congenital infection, so microcephaly, cataracts, rash, hepatosplenomegaly, jaundice, all the things that we've talked about on several occasions this week in regards to torch infections should all prompt a medical evaluation. Also, I've seen questions where they have a sort of a lateral picture of the child, and you can see significant wasting of the subcutaneous tissues on the sides of his or her buttocks, and really a concavity in that area, because that's one of the earliest areas where children lose subcutaneous tissue and muscle mass, the lateral buttocks. So is there wasting in other areas? Certainly any anatomic abnormality that makes it difficult to feed, or any neurologic findings that suggest for example, prenatal event, say hypoxia due to placental insufficiency, or a postnatal event, a difficult delivery, cord around the neck, and a hypoxic event there, bringing about neurologic findings on your exam. And then again, any evidence of hypothyroidism, again, prolonged jaundice and umbilical hernia. All right, so now you've decided that you better get some labs, because in your history or in your physical, there were some red flags that are drawing you away from just a psychosocial cause of failure to thrive. And all of these labs make sense, but it's going to depend upon the scenario that you're presented. So perhaps a urinalysis and culture or a urine for reducing substances, evidence of ongoing infection, electrolyte disorders, chronic renal disease, liver disease, evidence of malnutrition, evidence of hypo or hyperthyroidism. Again, perhaps if there's a history of foul-smelling stools and poor weight gain, sweat chloride, stool for reducing substances, serum ammonia, if there's concern about underlying metabolic disorders, serum lead, we'll talk about genetic testing. Again, all of these make sense. So refer back to what we talked about in terms of warning signs in history and physical exam to figure out which one might be most appropriate. Now, should you ever neuroimage? Yes, but it's going to be rare. We've been through the various neurocutaneous syndromes. There's the Lisch nodules and the cafe au lait spots with NF1. If there's a developmental delay, craniofacial malformations, et cetera, then yes, neuroimaging should be ordered. Okay? So, E. coli sepsis is most likely to be associated with which one of the following disorders? Now, let's say that this child has failure to thrive, now comes in with E. coli sepsis. Okay, great. So galactosemia. So what follows here is what I call the kind of the poor man's pediatrician guide to metabolic screening. And what I mean by that is these are some of the buzzwords you may read in a vignette in a child who is failing to thrive who needs a metabolic screen. So certainly one of them we just looked at. So vomiting, seizures, failure to thrive, E. coli sepsis, cataracts would be galactosemia. Episodic vomiting or lethargy may be PKU. Hepatomegaly is consistent with tyrosinemia. Unusual odors, both PKU and maple syrup urine disease. Sensory abnormalities, many of the mucopolysaccharidoses. Increased ammonia, increased liver functions, and seizures, urea cycle disorders. Acquired skin disorders, hyperlipoproteinemias, and then finally seizing with fasting or evidence of hypoglycemia are associated with your various medium chain deficiencies. So these last two slides hopefully are helpful buzzwords for you to read a vignette and understand that for this particular scenario, a metabolic workup is necessary and perhaps not neuroimaging, for example, or thyroid functions, for example. Now, when should you hospitalize someone for failure to thrive? Obviously, if there is a high risk of abuse and neglect, and the family of origin characteristics that increase the risk of abuse and neglect, and therefore oftentimes psychosocial failure to thrive, are outlined here. In addition, there are numerous other characteristics that you might read about in a vignette that would prompt you to recommend not outpatient of observation, but rather inpatient observation for feeding and perhaps additional workup. The patient, him or herself, should be hospitalized if severely malnourished, medically unstable, has failed an outpatient management regimen, or is in need for close observation because some of the concerns that were illustrated on the latter two slides are present in the particular scenario that you are presented with. Okay, so now we're going to talk a little bit more about head circumference and a little bit more about the difference between craniosynostosis and microcephaly, and look also at macrocephaly. microcephaly. So what might cause microcephaly? And again, kind of the theme of this particular talk is hopefully giving you information that you can memorize to take into your exam to work with in sorting through the information that's given in the vignettes. So a microcephalic child, this is why you need to know what the average head circumference is of a newborn, again, 37.5 centimeters. A microcephalic child is microcephalic due to genetic or chromosomal abnormalities, some due to, or for whatever reason, a reduction in brain mass and or development, various metabolic disorders, or the microcephaly may be due to a secondary cause. And some of the secondary causes are listed here as well. The head circumference will be provided for you in the vignette, and then perhaps some other bits of information that can help you come up with an etiology. Now, what's the difference between microcephaly and primary craniosynostosis? And this is important because the next best step is totally different depending upon whether you identify a child as microcephalic versus a child with primary craniosynostosis. The two key differences are the head is abnormally shaped with primary craniosynostosis. It's small with microcephaly, but it's not abnormally shaped. And the suture lines are palpable and thickened. They feel kind of like a mountain peak. So they might be described on your vignette as ridge-like or uneven. And those two characteristics, an abnormally shaped cell and palpable, thickened, peaked suture lines, are consistent with craniosynostosis. Whereas microcephaly, because it's due to underlying poor brain growth, that underlying poor brain growth leads to premature fusion of the cranial bones, but the skull is shaped normally, and again, the suture lines, although they are closed, they are not elevated. They are not ridge-like. So your next best step for primary craniosynostosis may very well be referral for evaluation by a neurosurgeon, and your next best step for microcephaly may very well be referral to a neurologist or a developmental specialist. So look for these key words to sort through those two. Also, keep in mind that skulls normally grow perpendicular to the suture line. So if this is the sagittal suture, normally this child's head is going to grow this way, perpendicular to the suture line. So if this is closed, therefore growth cannot occur perpendicular. Growth is going to occur this way, along the suture line. And that explains the most common type of craniosynostosis, which is primary closure of the sagittal suture leading to scaphocephaly. So remember that the shape of the head is determined by the fact that normal head growth occurs perpendicular to the suture. Most common, again, scaphocephaly due to premature closure of the sagittal suture. And you can see an example of it right here. Now, why do we have to be concerned about craniosynostosis? Because there may be ocular, neurologic issues, or increased intracranial pressure. So surgery oftentimes is recommended for far more reasons than cosmetic, because it can have a significant impact on the child's development. Now, craniosynostosis, by definition, most often is isolated to one suture. If multiple sutures are described in a vignette, you're probably dealing with a syndrome such as Crouzon's syndrome, or perhaps Apert's syndrome. And these are probably the two most common syndromes associated with craniosynostosis involving multiple sutures. Again, that's pretty unusual. Typically, it's just one suture like scaphocephaly. So multiple sutures mean additional workup and mean a much higher likelihood of an associated genetic or chromosomal abnormality. Now, we see plagiocephaly all the time. We know why, because the incidence of SIDS since the Back to Sleep program has thankfully dropped. But plagiocephaly has also come with some associated issues on its own, and I'm sure that some of you have patients right now who may be wearing helmets because of their plagiocephaly. However, you might be asked on your boards about the next best step, and if it's plagiocephaly, it may be observation or perhaps evaluation for a helmet. But plagiocephaly can look very similar to lambdoid craniosynostosis, and that would require referral to a neurosurgeon. So what's the difference between these two that you should be looking for in your vignette? The shape of the head, both abnormal, is somewhat different. Both are associated with ipsilateral occipital-parietal flattening, but the difference lies in the direction that the ear is displaced and whether the frontal bossing is ipsilateral or contralateral. So know these differences because the recommended treatment is very different between these two disorders, which can, especially at first, look very similar because of the fact that ipsilateral flattening in the occipital parietal area is present in both. All right, what about macrocephaly? Macrocephaly can be familial. It can be due to excess brain tissue or various skeletal dysplasias, but more worrisome, it can also be due to hydrocephalus, a subdural bleed, or a tumor. So in the vast majority of cases, these children, especially if they're younger, are going to need some degree of evaluation and workup. Remember that there are two types of hydrocephalus. One, obstructive, typically due to an abnormality somewhere in the aqueduct or a lesion in the fourth ventricle, or non-obstructive, which is typically more post-hemorrhagic or post-infectious in that preterm who has had an intracranial bleed, for example. And you can see, especially in these cuts here, that there's a significant enlargement of the ventricles, and this child would probably be in need of a shunt. So although it can be familial, and if you're given an option to measure the parent's head and the child is a little bit older, say 4 or 5, this is outside of the preemie period, I think that would be a reasonable first step to do, but it would certainly not be a reasonable first step if we were dealing with a neonate, especially if he had a history of being in the NICU. Okay, developmental surveillance and screening. So a couple definitions to keep in mind. What are developmental disabilities? Are impairments. Because there are developmental disabilities, we need to perform developmental surveillance at all times during preventive care visits. And that surveillance consists of having conversations with parents, identifying through those conversations various risk factors, and monitoring development. If surveillance brings about concerning information, and at specific times during well-child checks, screens should be used with standardized testing. So you screen a child, for example, for autism spectrum disorder, or you screen a child, for example, for language delay. So there's a difference between surveillance and screening. Screening is the action based upon what you learn from your conversation during surveillance. And then, if the screening raises major concerns, the child should be referred for a formal developmental evaluation. So just keep those definitions in mind from a well child care preventive pediatric aspect. So during developmental surveillance, again, this is a conversation with parents and caretakers about any concerns they may have. And it's important, and the Academy emphasizes this over and over again, to review developmental history, to try to identify any developmental abnormalities, and to inquire about all these various skills in accordance with the AAP Bright Futures recommendations. Now, in regards to developmental surveillance, you may come up with concerning information. So the next best step, once this concerning information is identified, is to move into more of a developmental screening and medical evaluation platform. And so whether they're prenatal exposures, birth complications, perinatal infections, underlying medical conditions or genetic conditions that you've identified, then obviously this subset of patients is going to need additional evaluation and consideration. All right, now, when do we screen and why do we screen and what should we screen? We screen because surveillance alone may miss some children with developmental and behavioral problems. And if you ever get a vignette that talks about parents raising concerns about X, it is almost never the right answer to say reassure and move forward, because you have to always take the parents' concerns to heart. So if they say, for example, I'm worried about language, and in your 2-minute assessment, your assessment seems okay, the correct answer is to refer that child for language assessment. Always trust the parents in regards to those comments during well child exams. So here are the recommended screens at 9, 18, 24, and 30 months, with all being important, looking at gross and fine motor skills, vision and hearing, language development, and any concern about autism spectrum disorder. Greater than 4 years, and you're assessing for school readiness at 4 years, and annual universal screening for any impairment of psychosocial functioning should begin at 5 years of age. How do we screen for those issues? Looking at any history of family disruption, change in school performance, onset of any behavioral difficulties, and the like. What screening tools should you use? The Academy has no recommendation. This is just some examples of the various screening tools that are available. Any of these are absolutely fine, and the important thing is to know when to screen, what to screen for, and what to do if that screening yields concerning results. Now, in specifics, we think we should look just for a second at autism. And at what age does the AAP recommend that all children be screened for autism spectrum disorders? Which of these age groups? Okay, 18 to 24 months, great. All right, so let's look a little bit more at autism, which is beginning to be identified in more and more children. And early recognition is critical, and therefore all children should routinely be screened at 18 and 24 months, and all children over 24 months at any time should also be screened if parents raise any concerning comments. Use the modified checklist for autism in toddlers. It has 20 questions, all of which should be answered yes, with 3 exceptions. Those 3 exceptions are listed here. And then once that has been performed, a score of 3 to 7 should prompt a second stage MCHAT, or a score of 8 or greater should prompt immediate referral. Which one of the following is considered an early sign of autism spectrum disorder? Absence of babbling by 9 months, of pointing and gesturing by 6 months, lack of orientation to name by 9 months, absence of single words by 12, absence of pretend play by 15 months. Great. Okay. So absence of babbling by 9 months. So here are the early indicators. Again, absence or babbling by 9 months, pointing or gesturing by 12 months, not by 6 months. Orientation to name, again, by 12 months, not by 9 months. Single words by 16, not by 12. Pretend or symbolic play by 18, not 15 months. And spontaneous or meaningful two-word phrases absent by 24 months. Any of these comments in a vignette that you're reading are going to be buzzwords for the possibility or the high possibility of autism spectrum disorder. Social interactions that you may read about in a vignette are outlined here. Poor eye contact, failure to respond to name, resisting physical contact. A lot of it sounds sort of similar to the child with apathetic withdrawal and failure to thrive that we mentioned early. That's social interactions. These are concerning language skills, and this is probably the most common presentation of children on the autism spectrum in regards to a delay in language skills. Behavioral components such as repetitive movements, certain rituals, interests in parts of an object, not a whole. My wife teaches kindergarten, and she's had several children in her class, and one little boy knew absolutely everything about trains, another about vacuum cleaner parts, and another about calendars. And one very characteristic thing with these particular behavioral components is if they are interrupted in any way, the children become very, very upset by that interruption. And that's another kind of buzzword that you may hear. Now, I'm not going to go through the rest of the handout. The rest of the handout answers these questions. At what age should a child do what? In terms of language, motor, and gross skills, it goes through various various red flags and the like. And what I would suggest that you do is I think number one, I think you know it all because you're very familiar with well child care, but I'm not sure it's very valuable for me to stand up here and read each slide to you, but that's provided for your information and for your reference.